Good afternoon, everybody, and welcome to today's IVF Series weekly live stream featuring, of course, Dr. Oybek Rustamov, a member of the Royal College of Obstetricians and Gynecologists of the United Kingdom, and has completed subspecialty training in reproductive medicine and surgery at Cambridge University Hospital's NHS Foundation Trust. And Dr. Oybek holds a postgraduate research degree from the University of Manchester and has extensive scientific expertise in the evaluation of ovarian reserve and ovarian stimulation in IVF cycles. For today, Dr. Oybek will cover four steps, and they are one, overview of the IVF cycle, number two, impact of age in female fertility, number three, female health in IVF, number four, female productive or reproductive diseases. Now, with that, Dr. Oybek will go through each steps that I just mentioned, and right after each steps or right after each topics, you guys can throw in some questions, and those who are watching us right now can message or send in your questions via www.rustamov.com.au or simply type in your questions by sending a direct message to our official Facebook page, which is, of course, facebook.com/rustamov. So without further ado, please welcome right now, of course, Dr. Oybek Rustamov. Doc?
Hi, Jesse. Thank you. Thanks for introduction. Thanks everyone for joining this live stream. I hope you had a great weekend and started great week. So what I suggest what we'll do is we'll go step by step. So I introduce first step. Then we will have some question and answer with GC. So if you have any questions, please write to social media. Then we can pick up an address and answer next live stream tomorrow. Okay. So the first of all, let me share my screen. Sorry. Okay. So first of all, why we're doing this live streams. So one of the purposes of live stream is to introduce IVF cycle to the members of the public, because IVF cycle seems to be very complex. If you even look at this chart, it looks quite complex because so many interventions taking place in such a short period of time. So actually, it is not that complex. It's quite simple treatment, provided we break it down into a number of steps. So that the patients undergoing IVF treatment know exactly which step they're at and what to expect from clinical point of view and logistics of the cycle in each and every step. So actually, we counted 50 small steps in IVF treatment. So we will be covering each step one by one. So initially, we will be doing short 5-minute live streaming for each step during the weekdays. Then every Monday and Tuesdays, then we'll have a longer live streams where we can answer the questions. So actually, during last 2 weeks, we covered all the 7 steps. Today and tomorrow, we will go over these 7 steps. Today, we will be talking this step 1 to step 4. Okay, so the first talk is overview of IVF cycle and plus overview of this IVF series. So, and we're talking at the moment IVF cycle in antagonist regime, which is most commonly used regime. So I will just go over the stages of IVF treatment briefly. So IVF treatment consists of 7 stages. First stage is baseline workup, which starts from the day patients see their GP and the specialist. It's actually the step before IVF treatment. So second stage is ovarian stimulation that lasts approximately 10 days, starting from the first day of the period till the trigger shot. Then stage 3 is egg collection, and stage 4 is egg fertilization, stage 5 embryo development, stage 6 embryo transfer, stage 7 luteal phase support, which is giving progesterone after the embryo transfer. So in terms of this IVF series, then we will go through steps in each stage. So let us say in stage 1, we have a number of steps. So one group of steps involves investigation and doing full review and workup for female patient. Second step, a group of steps involve reviewing male patient. And the next one is very important one is planning for individuals couple cycle. We call it cycle planning. So, and then stay in stage two, which we said, as we said, that which starts from the first day of the period, and that involves stimulation of ovaries that approximately lasts about 10 days in average. In some patients, it may last shorter, some patients may last longer. So that involves injection of gonadotropin drugs to stimulate the ovaries. It does say antral follicles, which are follicles less than 1 centimeter, can be stimulated and made dominant follicles, which becomes 18 millimeter or larger during this 10 day of injection, and which involves giving antagonist drug to suppress the pituitary, then monitoring of the cycle using ultrasound scan and blood tests, and giving the trigger injection. So the trigger injection kind of the last intervention in this stage. So we will cover all this during our live streams. So the third stage is egg collection. That is a ultrasound guided egg collection procedure. So we'll discuss what's involved in egg collection. So then we will discuss the eggs, the quality of the eggs and maturity of the eggs, how we assess. Then we discuss the quantity and quality of the sperm. Then move on to the next stage, which is fertilization of the eggs, which is usually next day after the egg collection process, when we will tell how we did the fertilization, whether did we use IVF or ICSI, what was the reason for using ICSI or IVF, and also, and we will discuss what's the normal rate for the fertilization. So then we move on to next stage, which is embryo development, which lasts until day 5. From day of fertilization till day 5, we will be covering development of embryos in each of these days. So, and then on day 5 and day 6, we check the embryos for their quality, and we will discuss and explain what is top grade embryo, what's borderline grade, what's poor grade embryo. So then next stage is the embryo transfer procedure. This is stage 6. We will discuss what's involved in that procedure. Then we will discuss luteal phase support. So luteal phase support involves giving progesterone, which starts before actually embryo transfer and continue until pregnancy test. If pregnancy test is positive, then we will continue until 7 week scan, then decide whether we should continue further or stop the progesterone. This period is called luteal phase. So this is pretty much it. So this is a quick run through. Next 2 months during this 50 short live streams and number of long live streams, we will discuss this in much more detail to explain everything in much more detail. Okay, so yeah, JC, this is my presentation for the step one.
All right, thank you so much, Doc, for that. And that was the overview of the IVF cycle, if I'm not mistaken. Now, we will move on with some questions, and feel free to throw in your questions in our social media pages also, where the live stream is being broadcasted. And also, you can message us at www.rustamov.com.au. Now, Doc, this is my first question to you. What do you suppose, or what does antagonist cycle mean?
Yes, yeah, antagonist. So we, of course, we have to use medical terms to communicate between ourselves, but sometimes it can be quite difficult for patients or members of public to understand. So essentially, we have few different type of regimes. So we've got something called protocol. The protocol is made for the patient, and you have a regime. So under regime, we understand what type of regime we use to down regulate the pituitary. What happens is normal menstrual cycle. If you don't interfere with body, so pituitary regulates menstrual cycle. It releases certain hormones like LH and FSH hormone. So if we don't block the pituitary during IVF cycle, so the pituitary may surge certain hormones and may cause premature ovulation. So we have to switch off the pituitary by drugs. Usually we use two different type of drugs for that. One is called agonist drug, and so second one is called antagonist drug. So this is the example of antagonist cycle, which is the most common type of IVF cycle nowadays because of convenience compared to agonist. And yeah, so antagonist means how we switch off the pituitary during the cycle.
All right, thank you so much, Doc. Actually, I have here another question. I hope it's perfectly okay for you to throw in one more question that I have here for the step one. Does this presentation cover all the steps of IVF cycle?
Yes, actually, all these 50 steps will
Hmm.
cover all of the antagonist cycle, everything essentially from, uh, we cover everything from the point of view of what is needed for the patient to know. And of course, there's a lot more in terms of medical interventions, but this will be sufficient for the patient to understand and navigate the IVF treatment cycle for antagonist cycle.
All right. Thank you so much, Doc, for clarifying that. Now, let's move on with the next topic, I suppose, or the next step, which is the impact of age in female fertility. Dr. Oybek, please.
Okay, so I will move on to female age. Sorry, it starts from the beginning, so I need to move to female age. Okay, so yeah, okay, excellent. So yeah, so I will carry on. Yeah, so okay, in this presentation we cover the impact of female age to women's fertility. Essentially, there seems to be two major factors when it comes to determine the women's fertility, which is their age and their ovarian reserve. These two things interact, and then they determine how fertile women are in terms of achieving the pregnancy. Yes, of course, there are a number of different other factors, but these are most fundamental factors because most fundamental unit for fertility in when it comes to the women is egg, yeah, gamete. When it comes to men, it is sperm. Yes, tubes important, uterus, everything else is important, but this is the most fundamental unit. So age appears to impact directly quantity and quality of that most fundamental unit, which is egg. Yes, so we'll explain it how it impacts. Okay, so this is second step, impact of age on women's fertility. Okay, so female age appears to impact both quantity of egg reserve and quality of the eggs in the ovaries. So let us examine how does impact the quantity of the egg reserve. So women are born with set number of eggs. They cannot create new eggs. All the eggs they have in their ovaries were created when they were in fetal life. So they cannot create, and they can only release the eggs or run out of eggs during their lifetime. Men can create do create sperm because they have stem cells that can divide and can create sperm during their lifetime. So the reserve of sperm is not issue really, but the egg reserve is a major issue when it comes to fertility. So and as women get older, the age reserve declines. So you can see from here then when women have the first menstrual cycle at the age of 13, they may have up to 350,000 eggs. That's in average. Some have more, some have less. Then as they get older, then the number declines. For example, if women trying to conceive at the age of 30, you can see that they already lost maybe approximately 70-80% of their reserve. So then it declines even further. So definitely, certainly, age affects egg reserve directly and significantly. And how do we know that? How we are sure that it definitely affects? Because when we measure the markers of ovarian reserve, like anti-Mullern hormone, which is direct marker of ovarian reserve, and antral follicle count, again direct marker of ovarian reserve, we can see these markers decline as women get older. So when these markers hit zero, then women cannot get pregnant. So we know there's a direct correlation between egg reserve and for growing follicles in antral follicles, or AMH, which is produced from growing follicles, and the fertility. So certainly age directly impacts egg reserve. So also live births when women trying to conceive naturally or through IVF declines significantly as they get older. So that's again linked to, yes, quality of the eggs and primarily to quantity also of the eggs. So then also we know that eggs can directly impact the quality of eggs. age can directly impact the quality of eggs. So how does it do it? So unfortunately, because of the effect of age, the structures in the egg cell can weaken and can get impacted by wear and tear, and may allow errors to happen when the chromosome division is taking place. So when eggs are created, in the fetal life, they created as a 46 chromosomes. So when just before the ovulation or after the trigger shot in IVF, so eggs should throw away half of the chromosomes, and we stay with only 23 chromosomes, because that 23 chromosomes should merge with the sperm's 23 chromosomes and create 46 normal chromosome. So because of this effect of the age, so the chromosome division doesn't happen in exact manner. So it's not in all eggs, not in all women all the time, but in most eggs, depending on the age. So the chromosome errors start happening, which means egg may keep one extra chromosome, end up with 24. We don't need 24 chromosomes in the eggs, we need 23, or may throw away extra chromosome and keep 22. So this is called aneuploidy. So aneuploidies can lead to abnormal embryos, and abnormal embryos can lead to failed implantation and miscarriages. So that is unfortunately direct impact of age to the quality. How do we know that? Because these research studies showed that the aneuploidy rate in the eggs increase with the age. Let us say at the age of 30, approximately 25% of eggs are abnormal, and when women were examined, women at the age of the age of 40, when they were examined, approximately 50% of eggs they produced had abnormality. So, and that also, in addition to that, the rate of miscarriages increased with increased age, and we know the most of the miscarriages originate because of aneuploidy, abnormal embryos, and most of the abnormal embryos linked to abnormal eggs. Yes, abnormal embryos can be linked to abnormal sperm, but in most of the cases it's linked to abnormal eggs, because sperm aneuploidy is only 10% generally. We can see here aneuploidy in eggs can be up as high as 50%. In patients older than 40, it can be even higher. So yeah, and also live birth rate declines. Again, it's directly linked to the quality of eggs and embryos or aneuploidy rate. So, and this presentation shows that age can directly impact to quality and quantity of the eggs, but again, doesn't mean that all eggs or most eggs are abnormal in all the patients. It means just it may be a little harder for them to get pregnant when they're trying to conceive naturally or using a fertility treatment. So it's simply proportionally they produce more abnormal eggs, and the eggs which are normal, they're essentially normal, and of course it can results in healthy babies. So this is end of my second presentation, GC.
Thank you so much, Doc. That was really, really intense. Now, I have here a couple of questions again that I'd like to throw with you. But then again, before I ask these questions, I'd like to mention again and tell our audience who is watching us right now to please feel free to throw in your questions in our social media pages where the live stream is being broadcasted. Also, you can message us at www.rustamov.com.au. So, Doc, here are my questions for the step two.
Okay, JC, I will be setting up for stage step 3. So, okay, 1 second. Live. So again, I have to go back there. Sorry. You okay, JC? So yeah, what I can do is I can start presenting. Okay, you're back. Okay, JC,
Apologies for that,
no, no,
Doc.
that's all right. That's all right.
Okay, so here's my first question to you. What is right age for starting trying to conceive?
Yeah, this is a good question. Actually, this is the individual decision. Yeah, the person's decision. So of course they have to take a lot of things into account, not only fertility, overall their life plans. Yeah, so then of course, and it helps if they know their individual fertility. They can do the test like AMH and antral follicle count, and take age into account. Then actually understand and know their individual fertility. Actually, when we discuss step 7, we will be discussing how we can do that using AMH test. So then once they take everything into account, then they can make a decision what age will be right age for them to try to conceive. If they're not planning to conceive immediately, they can do egg freezing, for example, if they especially have a low ovarian reserve, so that in case they need in future they can use. So the totally it's individual decision. And in terms of clinical point of view, of course, the earlier the better. So, and again, there's 3 different things. Yeah, there's like you have a chronological age, biological age, and fertility age. So there's some difference. So some patients may be older, but they may have a much better ovarian reserve, which is their fertility age, and they may have much higher chance of pregnancy. So yeah, so the best thing is to discuss if they're in relationship with their partner, and discuss with their GP and fertility specialist, local fertility specialist, and make informed decision. Yeah.
All right. How about doc? Why is it some women have different level of AMH? Despite having the same age.
Yes. So the AMH is produced from growing follicles. So the growing follicles are reflection of ovarian reserve, stored follicles. So the ovarian reserve is determined at the time of birth. Yeah. So you may have a 3 different level of ovarian reserve. So if women born with a very high level of ovarian reserve, and their ovarian reserve declines slower than average, and they have a higher AMH levels and higher ovarian reserve. So pretty much that's mainly genetically predetermined. It appears 70-80% of ovarian reserve is genetically determined, and this is why women who have family history of early menopause or premature ovarian insufficiency may be at risk of losing ovarian reserve faster. So yeah, so and also there's of course there's a role of epigenetics, and also a role of medical problems. So yeah, so the difference is mainly linked to the original ovarian reserve.
Doc, thank you so much for that. Now, I think it's time to move on to the next topic, which is the female health in IVF. So go ahead, Doc, please.
Okay, so I need to do slideshow without going back to the first step. So let me see if I can do that. So it's taking me. Okay, sorry guys. So I'll need to go back. Yeah, go to stage 3 by quickly moving through all the slides. Sorry about this. Okay, so next is female health. So in this short presentation, we will discuss impact of female health, general health, to their fertility and IVF treatment. So here, so when we discuss impact of overall health in fertility and fertility treatment and pregnancy, the main purpose here is knowing what health factors, health problems the patient may have before embarking upon fertility treatment. Second, analyzing the impact of this to analyzing impact of this health problem to fertility treatment and pregnancy and vice versa. And most importantly, modification of effect of these health problems to their fertility treatment and pregnancy and to the fetus. So, and this was extremely important for GPs and fertility specialists and patients themselves to discuss if they have any general health problems, which may not be related to their fertility, but general health problems. So, because the disease and the medication used to treat that disease can directly impact the fertility in IVF treatment cycle and the pregnancy. And interestingly, it's vice versa. Also, fertility IVF cycle interventions and pregnancy may impact the disease as well, and the treatment of that disease. So there is a interaction going on between disease and medication and treatment and pregnancy. And then this all these two factors can impact the developing fetus. Then once fetus is born, then it can impact the health of the child. When they grown up, it can impact their adult life. So this is why when we're doing initial fertility consultation, it's best time to understand all the diseases and medications patients taking, and modification of the impact of the disease and medications before we start fertility treatment. So of course, there's so many hundred different type of different health problems. We cannot cover all. We just run through quickly about of the most common ones. Then individual ones, need to be discussed for individual patients when they see the doctor. So okay, so the first thing is the factor which affects whole body. It's a generalized factor, which appears to be one of the main important ones is the body weight. So being severely underweight, which means BMI of less than 18, or overweight, BMI of 35 or more, can significantly impact the fertility and IVF cycle and pregnancy. So the optimal body weight is of course 18 to 30, 18 to 25, but 18 to 30 is pretty much very acceptable. And we can treat patients from up to the BMI of 35, provided they don't have additional risk factors. But once patients, if the patient has a BMI of 35 or more, then certainly we need to achieve optimization of their weight before they can have the treatment. So next is unfortunately mental health problems is not uncommon, and the patient again that can directly impact the fertility and fertility treatment and pregnancy, and also medications used for mental health problems can impact the fertility treatment and pregnancy. So that's why it's very important to liaise with the GP of the patient or any other specialist who's treating the patient, and to try and modify the effect of these factors before we can embark upon fertility treatment. So then anemia, unfortunately, common, not uncommon. It's linked to modifiable factors like iron deficiency, vitamin B12 deficiency, folate deficiency, which can be replaced, and anemia can be treated before fertility treatment. So, and again, abnormal thyroid function, hypothyroidism, which means being underactive thyroid, is not uncommon, and the thyroid hypothyroidism can directly impact the fertility, IVF cycle outcomes, and pregnancy. Hence, the optimal level of TSH, which is TSH should be achieved, which is normally less than 2.5, and which can be achieved using thyroxine replacement therapy. So we also check patients for insulin levels and fasting glucose levels to ensure that they don't have a diabetes. If they have insulin impairment, the glucose impairment, then it needs to be corrected, and optimal HbA1c should be achieved before we can embark upon IVF treatment. And we also take detailed history of surgical procedures, previous surgical procedures, because pelvic abdominal procedures, even other medical surgical procedures, can directly impact IVF treatment. And abdominal pelvic surgeries can impact the pregnancy and management of pregnancy and childbirth. That's why we have to understand and know what surgical procedures patient had in the past, and take this into account when we formulate treatment strategies. In terms of so essentially we have to go through systems and ask patients if they have any medical conditions, neurological, gastrointestinal, renal. So if they do, then we have to understand the full history and modify their effect impact to fertility, IVF treatment, and pregnancy. And lifestyle factors plays major role. It's important for women to be on balanced diet when they embark upon fertility treatment, and stop smoking and or recreational drugs, stopping or minimizing alcohol, especially after embryo transfer, is extremely important, and doing moderate level of exercise is recommended, because strenuous exercise can impact fertility and IVF treatment cycle and pregnancy. So overall, once we find out the health conditions of the patient, once or if provided we modify the impact of fertility in IVF treatment and pregnancy, we that allows us to have a desired outcome, which is healthy baby and very healthy and happy mom. Okay, so JC, this is my third presentation.
Thank you, so much, Doc, for that. That's the female health in IVF. Now, here are a couple of questions again I'd like to ask you about this, step and topic. First one is, what is your recommendation to women who have, multiple medical problems and then wish to get pregnant?
Yeah, so first of all, I would recommend the patient should discuss with their general practitioner, because general practitioner knows background history of the patient, and they got all the information about their medical history, previous medical history. So before starting to get before trying to conceive naturally, they have to have a preconceptual counseling or discussion with their general practitioner, and establish the effect of all these diseases to their fertility and pregnancy and health of the future child. So and often if patient has multiple medical conditions, it often requires to involve specialists, individual specialists who is looking after the patient, or getting additional opinion from specialists. And in some diseases require even involving obstetrician before pregnancy, because that you have a two different once you overcome fertility problem during pregnancy, you have two different type of problems. One, managing medical condition during pregnancy. So then managing pregnancy with patient with medical condition. You have to manage medical condition, because pregnancy can directly impact that medical condition, and vice versa. So you in each obstetric unit, you have specialized obstetricians who specialize in managing medical problems during obstetric care. And often it's often if patients have multiple conditions, we ask obstetricians to advise before even we start fertility treatment. So in most conditions, women can conceive and have a healthy pregnancy, but it is really strongly recommended they need to review before pregnancy and prepare for pregnancy.
Thank you so much, Doc, for that. Now, one more question with regards to this topic. Why is it that you do not recommend fertility treatment in women with, high BMI?
Yes, good question. So overall, in terms of high BMI, because BMI is high BMI, let us say obesity or severe obesity, can have a systemic effect, certainly to fertility and fertility treatment itself. It can increase the risks during fertility treatment, and obstetric complications, antenatal complications. So of course, in individual, we approach patients individually. So if the time is not major problem, certainly we should do our best to modify the weight and optimize the health of the patient before fertility treatment. But in certain occasions, let us say, unfortunately, sometimes we need to do emergency IVF for egg freezing, for various cancer or different conditions. Here it's different. So we have to assess risks and benefits of each intervention. And if in terms of fertility treatment, certainly a modification of the overall health should be priority.
All right, thank you so much, Doc, for that. Now, I suppose it's time for us to move on to the last but definitely not the least topic, which is, of course, the female reproductive diseases. So, Dr. Oybek, please go ahead.
Thanks, Jesse. So again, I need to learn how to do a present, this full screen presentation without going to the first slide. Okay, sorry if I go back to first slide. Okay, so yeah, so I did. Sorry, guys. So quick slide overview. Oh, I need to learn how to do it. Okay, so this is female. Oh yeah, yeah, here. Okay, so this is the last presentation for today. Female reproductive health, step 4 of IVF series. So here it's step 4. So okay, so yeah, essentially here we will discuss and review common reproductive problems which we encounter when we are treating patients with IVF, and how we overcome the challenges these reproductive problems pose to us. So these are most common ones are endometriosis, ovarian cyst, hydrosalpinx, fibroids, uterine polyp, and uterine abnormalities. Okay, let us step by step. First one is endometriosis. Unfortunately, endometriosis is very common. It's believed that approximately 10% of women have endometriosis in general population. In patients with infertility, 25% of women may have endometriosis. It's actually 1 in 4 women undergoing IVF or fertility treatment may have endometriosis. Unfortunately, it's common. It can cause some difficulties depending on the stage of endometriosis. Endometriosis has 4 different severity. Stage 1, stage 2, stage 3, stage 4, which is most severe. Again, that also determines the impact of endometriosis to IVF treatment and overall fertility. So it has 3 major impact. One is impact to ovarian reserve. Second is access to ovaries for when we do ultrasound scanning, and impact to embryo implantation. So in terms of ovarian reserve, if the patient has a severe endometriosis involving ovaries, directly involving ovaries, or endometriotic cyst on the ovaries, which is called endometrioma, that can impact ovarian reserve, especially if patient has a large endometriotic cyst. If we need to excise the cyst, then it can reduce their ovarian reserve even further. Small endometriotic cysts do not usually require excising or treatment before IVF treatment, but if endometriosis is large, and that may require surgical treatment, which can reduce ovarian reserve further. So second is access to ovaries, especially if endometriosis is large, that can displace the ovary and make it very difficult for us to see when we do transvaginal scan. When we use a transvaginal scan in IVF, which is vaginal scan, so usually the vaginal scan, they can show us approximately up 10 centimeter from the tip of the probe. If patient has a very large cyst and it displays the ovary much higher, we may not be able to see the ovaries fully, and that can make it difficult for us to reach the ovary and collect eggs from that particular ovary. So access can be reduced because of endometriosis. And also endometriosis can cause adhesions. So ovaries may be stuck because of endometriosis much higher up outside the pelvic brim. Again, that can make it difficult to access the ovary. So the third impact is impact to embryo implantation. So it appears that endometriotic cells, even if they're outside the uterus, they communicate the cells, normal endometrial cells, inside the uterus. So that can actually reduce implantation. So especially severe endometriosis can reduce implantation. So and other form of endometriosis called adenomyosis, where endometriosis grows inside the muscle layer of the uterus. So let us imagine here you have got endometrial plate, you have a kind of stem cell plate, very clear demarcated line, which should not be breached by the endometrium. In adenomyosis, that endometrial cells can breach into the through the plate and end up inside the muscle layer and can cause cavitations, can cause inflammation. So that's called adenomyosis. So, and this localized inflammation and discharge of endometriotic fluid into the cavity can impact implantation. So, and this is one of the major impacts of endometriosis. So, second disease is ovarian cyst. There are different types of ovarian cyst. Simple follicular cysts usually don't cause any problem, which is just simple fluid collections. Usually they disappear within a few months. They don't cause major problem to fertility, but certain type of cysts and can cause significant impact. So they can impact ovarian reserve, ovarian response to stimulation, and they can reduce access to the ovaries. In terms of ovarian reserve, usually two different type of cysts, endometriotic and dermoid cysts, can directly impact ovarian reserve. And also removal of these cysts can reduce ovarian reserve. What happens is these cyst walls have a very dense attachment to the ovarian cortex, which is outside layer. So ovarian cortex contains tiny invisible primordial follicles which contain eggs. When you strip off this cyst wall, inevitably you end up removing some of the sleeping tiny eggs. So if patient has got high ovarian reserve, it may not be significant. If patient has a low ovarian reserve, that can reduce ovarian reserve even further. So, so we're talking about the benign cyst, yeah. So we're not talking about non-benign cyst. So, in terms of benign cyst, endometriotic cysts and dermoid cysts are common, and they can impact ovarian reserve. So, and then the cysts can reduce ovarian response in IVF when we stimulate the ovaries. So especially if cyst is very large. Let us say you have two ovaries. One ovary has a very large cyst, let us say 10 centimeter cyst, occupying most of the ovarian space, and there isn't much space for the follicles to grow and become large because this, the space is taken by the cyst, and that can reduce ovarian response in that ovary. So also, cysts can cause adhesions around the ovaries. Then ovary can interrupt between the adhesions. So ovary needs to be free to grow the follicles. If it's interrupted inside the adhesions and tissue, it cannot. It may have a follicles and eggs, but it cannot grow the follicles, because just imagine follicle is 1 centimeter before stimulation, it ends up becoming 2 centimeters on average. Let us say 10 follicles of 2 centimeters needs so much space in the pelvis if the ovary is entrapped, and you often see poor response to stimulation. So, and the third impact is the impact to the egg pickup. Again, if ovary has a large cyst, it can displace the ovary and may make it difficult to reach the ovary during egg pickup. So then that could be the reason for difficulties. So this is the impact of the cyst. Third is impact of hydrosalpinx. So hydrosalpinx is infection of the tube. The tubes should be very narrow, agile, mobile. But in hydrosalpinx, what happens is because of infection, usually it's caused by chlamydia, maybe caused by different type of infections. So the inside the cells of the tubes get infected, inflamed, and produce fluid, and that fluid doesn't get absorbed back into the system, and you end up having a sac-like structure shape in the tube. So it's filled with the inflammation fluid. So this fluid sitting inside here, if it communicates back with the uterine cavity, it can be toxic. It can actually wash away the embryo, or it can cause problem with implantation. So yes, women can have implantation with the hydrosalpinx, but simply their chance reduced by 50% if they have a hydrosalpinx in IVF without removing of the tube. So, and this is why it's strongly recommended hydrosalpinx should be removed if it's possible before transfer of embryo. So, and also large hydrosalpinx can reduce access, because if it is large, and again it can displace the ovary, it can cover ovary, it may be difficult to see the ovary clearly, and also it can cause adhesion around them, scar tissue, and envelop the ovary around them. So and also can cause difficulty in egg pickup because of displacement and also adhesions, and also it can cause infection. So this is why we give antibiotics during egg pickup if patients have hydrosalpinx, to reduce risk of infection. So, and the embryo transfer, we have discussed, it can reduce chance of embryo transfer. Usually, if you diagnose hydrosalpinx before IVF, usually we recommend treatment of hydrosalpinx, which means removal of the tube, because the tube is already damaged, and the chance of having successful pregnancy using the damaged tube is low, especially if patient is undergoing IVF treatment. If they have access to IVF, then it's recommended to remove the tube before the IVF treatment. If you diagnose hydrosalpinx during IVF treatment, you usually freeze the embryos. Then before doing frozen embryo cycle, we recommend removal of hydrosalpinx. So fourth disease is uterine fibroids. Unfortunately, again, it's quite common. Approximately 10-15% of women have uterine fibroids. Really, the impact of uterine fibroids depends on two things. One is their location, where they are located in the uterus. Second, their size. So in terms of location, you have three different type of fibroids: subserous, intramural, and submucous. Subserous means the fibroid is protruding outside the uterus, inside the pelvis. Submucous fibroid is fibroid protruding inside the uterine cavity. Then intramural fibroid, the fibroid right in the middle of uterine wall. So, and that determines their impact. Also, size of the fibroids plays important role. If let us say, for example, if intramural fibroid it's quite large, more than 5 centimeters, for example, it can start distorting the cavity. Here you can see it's distorting the cavity. Then drainage of the cavity gets impacted, and you often see the collection of endometrial fluid in the cavity. Of course, it significantly impacts the implantation. And if you have a multiple fibroids, yes, three things actually: location, size, and number of fibroids. If you have a multiple number of fibroids, different fibroids growing from different place of the uterus, that can also significantly impact implantation. So subserous fibroids usually do not impact fertility because they're really protruding outside unless they're really big. And submucous fibroids have a direct impact to fertility because they reduce implantation, because this fibroid is just sitting just under the endometrial plate. So what happens is endometrial embryo should just implant and grow its placenta through endometrial plate and make a connection with the spiral arteries to the maternal mom's uterus. So if you have a fibroid sitting here, that can impact significantly because fibroid doesn't have a blood vessels. So the embryo cannot attach and grow its placenta through the fibroid. If embryo unfortunately implants here on top of the fibroid, then it can fail. It can cause failed embryo transfer, biochemical pregnancy, or miscarriage. So, and that's why submucous fibroids need to be treated. They need to be removed before embryo transfer. So submucous fibroids cannot be removed. So they're too dangerous to remove, and then it can be treated by injections, for example. So most submucous fibroids, which is protruding inside the cavity, fully or almost fully or more than 50%, and if they're not very large, they can be removed with hysteroscopy procedure, and or most fibroids can be removed through laparoscopy or laparotomy procedure. And again, intramural fibroids, if there are multiple intramural fibroids, they need to be removed with keyhole surgery or laparotomy. So, so this is the impact of fibroids. And also, if fibroids is very large, it can displace the uterus. It may make it difficult to reach the ovaries for egg pickup because with the fibroid, everything grows up whole uterus, whole ovaries, that it will be difficult to see the ovaries and get eggs during IVF cycle, and hence in patients we recommend having myomectomy before IVF treatment. So and access and also fibroids can impact the pregnancy, especially if it's multiple large fibroids, and that need to be discussed and modified before IVF treatment if we think that fibroid is going to impact the pregnancy. So next disease is uterine polyp. Yeah, so this polyp is quite small, benign growth growing from the endometrium lining. Difference between polyp and fibroid is fibroid grows from muscle layer of the uterus. Polyp grows from endometrial inside layer of the uterus. Both of them benign. So, and again, small polyp sitting inside the cavity may cause localized reaction, not infection, inflammation, and that can reduce implantation, and it can cause bleeding. Which reduce implantation, and simply even embryo is so tiny it can just implant on top of polyp, but it cannot grow its placenta through because the polyp doesn't polyp doesn't allow placentation. So and yes, if mice, it appears that small polyps may not impact implantation that much, but any significant in the large polyps, if especially polyp is more than 1 centimeter, it's best to remove the polyp before embryo transfer. So last pathology is uterine abnormality. So these are uterine abnormalities are developmental abnormalities. So you have different levels. So in fetal life, the uterus grows from two sides and meets in the middle, merges fully, and then you don't have any septum or any abnormality in most women. In some women, this process doesn't get completed fully, and they may have some abnormalities. So that number of different types, most common ones: uterine septum, bicornuate uterus, arcuate bicornuate uterus, and didelphys. Didelphys is not very common. So in bicornuate uterus is most common type. You have different type of bicornuate uterus. In minor bicornuate, not bicornuate, septate uterus. In partial septum, you may have just small septum on top. Let us say if you imagine uterus as a room, you have got smooth wall, and from the ceiling you have got some septum, which is dividing wall hanging. So if it's my small septum, that's called minor. Partial septum, septum may reach here, like it is partial, it's not full septum, but it is reaching to lower one-third of the uterine cavity. Then you may have a full complete uterine septum. It may reach up to here, including cervix. Then in some patients, the septum can extend to vagina. So depending on the extent of septum, it can impact fertility and pregnancy in different degrees. So the main problem with the septum is twofold. One is it can significantly impact implantation because septum doesn't have a blood vessels; it just has a connective tissue. Opposite to the septum, or wall of the uterus has a muscle layer and blood vessels. So where if embryo implants here, it can grow its placenta and develop into full the embryo. If embryo implants on the septum, it doesn't have a blood vessel, it cannot grow its placenta, and embryo may fail to develop. So this is one problem. And second problem of septum, it can cause miscarriages depending on the late miscarriages, early or late miscarriages, or premature labor depending on degree of septum, because septum cannot extend like uterine wall because it's connective tissue, like pulling the uterus in the middle, and it can cause late miscarriage or premature labor. And so generally it's recommended to remove the septum before embryo transfer. Second part of the type of common problem abnormality we see is bicornuate uterus or arcuate uterus. This one is bicornuate. If you have a less severe change in the shape, then we call arcuate uterus. So main difference between septum is bicornuate uterus. Here you have a muscle layer. It's not connective tissue, and hence it doesn't really reduce implantation. If embryo implants here, it can grow its placenta, Yeah, so it doesn't cause implantation problem, but it can cause miscarriages, especially late miscarriages when embryo is growing fast, late second trimester, third trimester. It may cause premature labor because it cannot stretch as much as normal uterus. So uterine didelphus, you have a two uterus here. Difference between didelphus and septum. Here you have a muscle layer. Actually, the two uterus merged, two from two sides they came and merged in the middle, and you have a muscle layer. Essentially, you have two uteri here, and it because it's muscle layer here and all around, and doesn't really impact implantation. And wherever the embryo implants, it can grow its placenta, but unlike in septum. And so the main problem you may have is in later pregnancy. It may, because of limited space, it may trigger of late miscarriages or premature labor. Usually, it's not recommended to do any intervention for this before fertility treatment, and just simply patient and obstetrician, the GP, have to be aware that this abnormality patient has, and they need to monitor during pregnancy. Yeah, so these are six conditions we see quite often, and there are different ways of managing these problems. And most importantly, we should try and identify these problems before IVF cycle, and make a plan for treatment of these conditions, or freezing embryos before we treat these conditions. If we come across these conditions during IVF treatment, we should discuss with the patient impact and make a plan. And if we think this condition is going to impact their embryo implantation, then we have an option of freezing of all the embryos, then addressing these problems before we transfer embryos in frozen cycle. Okay,
All right.
so yeah, Jesse, yeah, that's the end of step 4. Yeah.
That's right. Thank
Yeah.
you so much, Doc. That was the female reproductive diseases, right? So I have here a couple of questions again for you. Specifically, I mean, you have been mentioning a while ago, a lot of times actually, that, about that fibroid. Does it cause, infertility?
Yeah, good question. Actually, fibroids are common. 10, 15% of women, like millions of women, have fibroids. Most women don't have any fertility problem. They conceive naturally. So certainly, the women with fibroids have a much higher chance of infertility because of this the impact to the fertility. Um, yes, so in some patients, it may not. In some patients, this may impact maybe one of the factors, one of many factors which can cause causing their infertility. In some patients, it may be only factor which is causing infertility. So again, depending on location, degree in terms of size, and the number of fibroids they have, it can affect fertility in different levels.
All right. Now, here's another question that I'd like to ask you, Doc, because I heard it during your presentation for that step 4. What does adenomyosis mean?
Oh yes, adenomyosis is a type of endometriosis. So actually, endometriosis means so endometrium, which is the lining of the uterus, should be located only inside the uterine cavity. So in endometriosis means that this lining cells of endometrial cells end up outside. So they can end up outside in the pelvis. It can end up on the bowel, uh, on the surface of the ovary, uterus. These are all everything outside the uterus called endometriosis. And one type of endometriosis where the endometrial cells end up inside the uterine wall called adenomyosis. Technically, it is endometriosis just because of its location, a specific location in the wall. We call adenoma. Let us say again, if you imagine uterus as a room, so you have got an endometriosis lesion inside the wall of that room. So that is called adenomyosis. This type of endometriosis, yes.
All right, thank you so much, Doc, for that. And there you have it, ladies and gentlemen. Those are extensive presentations on the overview of the IVF cycle, impact of age in female fertility, female health in IVF, female reproductive diseases, of course. Now, please go right ahead and check out all our social media pages and our website, www.rustamov.com.au, for more information. And tomorrow, again, we will be doing another exciting discussion. Please join us again at exactly 12 noon for another episode of IVF Series Weekly Live Stream. Doc, please do invite them once again for tomorrow's next episode of IVF Series Weekly Live Stream.
Thank you. Thanks, Jesse. Thanks for kindly hosting the event, and thanks everyone for your time. And I wish you a great day ahead. And we'll see you next time, next tomorrow. Thank you. Thanks for your time. Thank you.
Thank you, everybody, and enjoy the rest of the day. Thank you so much, Doc, and see you tomorrow.